Okay, ji. Assalamu alaikum. This is Dr. Sonia here. We're going to start with the next topic of the embryology. We have already discussed the formation of the embryogenesis. That is all what that was first 3 months, what all was formed in those 3 months. Now we said that we're going to continue with the next period, and that 3 months onwards is the called the fetal period. That is what all has the foundation stone of what all has been laid down is going to grow in size, and it's going to grow in weight. So that is the period that we call as the fetal period. It is the ninth week onwards to the birth time. Now, the prenatal development has been divided, as I told you already, three stages. The first 2 weeks after conception was known as the germinal stage. Then the third to the eighth week is known as the embryonic period, and ninth week until birth is known as the fetal period. And then again, they are also divided into three equal trimesters, but they do not correspond. That's not exactly with the embryonic period or the fetal period. It's just the calendar months. That is first 3 months, and then the second 3 months, and the last 3 months. They are called the three trimesters. So they may be overlapping the embryonic and the fetal period or the germinal stages. So they are different from those as the embryonic and the fetal periods. These are the three stages that we see in which the different phases of development start. This is the germinal phase, when there is fertilization, there is gametogenesis, fertilization, then there is implantation, then the mitotic process starts. That is second, up till the second week that is there. Then is the embryonic period. That is your the dilaminar or the two-layered structure divides into three-layered trilaminar disc is formed, and then gradually onwards the neurulation, gastrulation, all those stages in which the implantation along with these more of the placenta is formed. Then there is these layers, they start to differentiate into the different organs which are there. So you can say the foundation stones of all the systems are laid down, and they are then going to gradually increase in size. Then onwards in the fetal period, that is 9 weeks to birth onwards, that is what all has been laid down is going to grow after after the embryonic period. Fetal period, as we say, is the third month to ninth month. The maturation of the existing structures is what is going to happen in the fetal period. As the embryo enlarges, now we are going to call it the fetus. Till the third month, we were calling it the embryo. Now it is going to be called as the fetus. It enlarges to become a fetus. And this in this process, what all happens is that the maturation occurs. Further of all, what the foundation stones were laid for further proliferation, differentiation, and morphogenesis, that is change in shape, size, all that is going to occur. That is what started is going to process further to all extents. The transformation of an embryo to a fetus is gradual. That is, initially it's just going to grow in size. Weight growth is at the end of the pregnancy. The embryo has developed into a recognizable, at this stage we said it is has achieved a stage what we call as the recognizable human period. If you see in this picture, it is roughly resembling a human shape. That is, you can see where you have the brain, you have the nose, eyes, where the heart is, where the limbs are started to develop. So that is what exactly we mean, that it has given a recognizable human being, and that the primordia of all the major systems have formed. Fetal period is primarily concerned with this rapid body growth, and which is that is what structures started with going on further rapidly, and differentiation, organ systems, all that is further maturation of all those systems is going to occur. There is now the differentiation is that the head grows slow. As initially when you see in the development, you will see that the size of the head is bigger as compared to the rest of the body, but in later phases when you have the fetal period, the body grows more as compared to the head. So that is a big change that is going to occur. So there is relative slowdown in the growth of the head as compared with the rest of the body. The rate of the body growth during the fetal period is very rapid. That means all the structures are going to increase quickly. But the fetal period weight is slow. It's just in the terminal 2 weeks, that is the major gain in weight of the baby occurs. So growth occurs majority throughout after 3 months, and the weight is just more gain in the last 2 weeks of the development. Now, all the major structures have already formed, as we've already said in the embryonic phase, because that is the foundation stone in the fetus, but they continue to grow and develop. because the precursors of all the organs, that is initial differentiation, has occurred. And we said during the embryonic period it was more sensitive stage, and anything exposure to any teratogenic structure was harmful for the baby. But now at this stage the fetus is not as sensitive to the damage for the environmental exposure as the embryo was, because all the differentiation had occurred, and what has differentiation is not going to increase in size. So the critical phase that can be for the baby is the first 3 months. Instead, toxic exposure often causes physiological abnormalities or minor congenital formations, but still different modification is occurring. So it's not that any exposure will not do any harm. It may harm, but it is not as sensitive as it was in the embryonic period. The length of the pregnancy is 280 days or 40 weeks after the onset of the last and normal menstrual period. After, if you say that is LMP, that is when the menstruation finished and the proliferative phase start, that is equal to 280 days or 40 weeks. But if you start counting the length of the pregnancy from the time of fertilization, which occurs 2 weeks after the initiation of this proliferative phase, so that means 2 weeks would be less. It is 38 weeks and 266 days. So because fertilization occurs 2 weeks after or 15 days after the start of the next cycle, so that is why there is a difference. So if that depends on a rough estimation, when you want to count that at this time the fertilization occurred, and this could be the probable expected EDD or the expected delivery date. And if you start counting from the, because that date cannot be told by the mother, but when she finished her cycle, that is what the mother can know. And so that is, and if all these are not clearly known by the mother, then it's just the fundal height with which you, or by the ultrasound, if you see these somites and all the formation and all these stages, they can help you at exactly what is the time period, whether it is the embryonic period or the fetal period, or what could be the probable pregnancy date be, the delivery date be. Estimation of fetal age, that's important. As we said already, that the crown round length, that is from the vertex up till the area between the mid of the buttocks, that is taken as to determine by, that is ultrasonography, the probable size and the probable age of the fetus, and to provide a prediction of the expected delivery date. So these are fixed ratios in the expected the ultrasonography, and those, with those calculations, you can assess the expected delivery date. Fetal head measurements and femur length are also at times used to evaluate the age. Gestational age is commonly used clinically. The length of the fetus is usually in the crown rump length, sitting height. Standing height is the crown heel length, that is up till from the vertex onto that. Both these can be measured. The measurements expressed in centimeters are correlated with the age of the fetus in weeks or months. So that is a table is formed. Growth and length is particularly striking in the third, fourth, and the fifth months, and increased weight, again, as we said already, its last 2 months. So third, fourth, and fifth months, and sixth roughly, and the seventh onwards is, that is eighth and ninth month, is the gain in weight. You see this diagram shows you gradually 9 weeks, 12 weeks, then you have the 20th week, and then 28th and the 30th weeks. That is all the different phases which are gradually increasing in size, and the in different differentiations that is occurring. Then you have the trimesters of pregnancy. What are these? These are clinical gestation period is divided, that is the time of the pregnancy is divided into 3 trimesters. Each is lasting 3 months. First, all major systems are developed. Second, fetus grows sufficiently in size. So at times, roughly what we say is that first trimester of the embryonic period is considered as the first trimester, when all the major systems are developed. Second trimester, fetus grows sufficiently in size. Good anatomic details can be visualized by ultrasound. Most fetal anomalies can be detected because the differentiation has occurred, so you can figure out if any fetal anomaly is developing in the baby. And the third trimester may survive if born prematurely. That is, at this phase, a major developmental landmark is 35 weeks. If at 35 weeks, if the baby is born, he may survive, and that is would be a prematurity. His weight is approximately 2,500 grams used to be definite level of fetal maturity. That is, if 35 weeks and 2,500 grams is the cutout, this can be a landmark that the baby may survive, because it is most of the systems have developed and he has attained a definite level of fetal maturity which can be, the baby can survive. Growth rate. The growth rate of an embryo and an infant can be measured by uh, uh, an abnormally slow rate results in the infant being small for that gestational age. That is what exactly the size the baby had to be in that time period. Is if it is less, that is going to be small for the gestational, and if large, it is going the growth is fast, then it is going to be large for that gestational age. So there are fixed landmarks, that is in the certain time period, this much growth, this much development has to be there, and if it is more or less, it's going to be small or large for gestational age. A slow growth rate and preterm baby, that is prematurity, are two factors that can cause a because if the baby is not fully mature and the baby is born, that is premature birth is there, then the baby is going to be of low birth weight. If the growth initially was slow and the baby is born before the full term, that is 9 months, then the baby would definitely be of low birth weight, as because we've said that the baby is to increase its weight in the last 2 months. The growth rate can be roughly correlated with the fundal height. That is, again, that as already said, the height of the uterus. That is, if you estimate with the physical examination, that can be seen, that because that is going to increase in size according to the growth of the baby, which can be estimated by abdominal palpation. More exact measurements are taken by obstetric ultrasonography, because there you have the measurements of the bone, you have the measurements of the fetus, crown round length, crown heel length, then this head circumference, all these, because there are certain measurements which can be taken, and then you assess them along with the definite timetables, that whether the baby is growing okay or the growth is slow or very fast. Yeah. Then is what, at what time period, what weight, what height, the viability of the fetuses. That is, if the baby is born, the baby can survive. This is defined as the ability of the fetus to survive in the extrauterine environment. That is, whether premature or full term, that those features have to be fulfilled, so that it would be a premature birth, but because the fetus is of appropriate size, appropriate height, appropriate weight, the he or she can survive if given good care. So that is viability of fetus. Fetus weighing less than 500 grams does not survive. Full term baby, but still low birth weight, if there is some problem with the increasing in the weight, results from intrauterine growth restriction. That can be a reason which the baby may not survive, or may be critical or very good. Postnatal care has to be given. Fetus weighing between 1500 to 2500 grams usually survive, but complications may occur. They are also considered as premature infants. So, the again, the weight, height, all the factors have to be fulfilled before you can label the baby as a full term baby, and that which is safe to survive. But these, if uh, are going to be a premature, if a premature baby is born before 9 months and the weight is between this, they can survive, but complications or risk is there that there may be, if not given proper care, the baby may not survive. But there are more chances that they can survive. But if it is less than 500 grams, the baby will not survive. Prematurity is one of the most common cause of morbidity and perinatal or prenatal death. That is, the chances of fetal death is prematurity. That is because when the baby, every development is going to take place at a certain time period. If the baby is not going to go, is born before that time period, naturally that changes have not been occurred. That is, the if supposing the this lung have not developed properly, then the surfactant that would have not developed. This surfactant is that which prevents the lung alveoli to collapse. And so if the surfactant has not been formed, that is, then there are chances that the baby will not be able to breathe properly, and chances of survival would be less. So, but if there are certain chances that there is threatened abortion, that the premature term is to be reached, that is the baby, there are chances that the it cannot be helped out, and there has to be a birth or a prematurity birth is predicted, then it's seen given that this surfactant artificially or steroids, they are given to the mother through the to the baby through the mother, so that they can quickly or quicken the production of or maturity of the lungs, so that if the baby has to be born before time, then the lungs would be mature and the baby would be able to survive. So this is important that a premature baby, if certain factors, that is, even if the baby is premature but the weight is okay, the systems have developed properly, the growth is proper, then chances of survival are more and less chances of abnormalities are there. The How do you measurements and the characteristics of fetuses? Various measurements and external characteristics are useful for estimating the fetal age. All this is uh, to assess what is the age of the baby. Crown rump length choice for estimating is in the first trimester. In the second and the third trimester, ultrasonography is done. You can measure the head circumference, biparietal diameter. You can measure the abdominal, female length, foot length, all these. And that is, first it is the crown rump length in the first trimester, first 3 months, and the second and the third trimesters you can measure all these other features, so that you can estimate the age of the baby. Determination of the size of the head is also helpful for the birth, whether the baby is going to pass, if it is estimated that the pelvis is small, whether the head is going to be passed through that birth canal of the mother, so that a size in the end in these time periods can also give you an estimation that whether the normal delivery can be there, whether the head can pass through, because head is the approaching or the advancing part of the fetus, which is going to pass through the birth canal, and then whole of the baby is going to pass out. And if the head circumference is large and the pelvis size of the mother is small, then the baby cannot pass through that, and so the gynecologist has to design a C-section. So for that, measurement of this head circumference is also important. Highlights of the fetal period. What steps are there, that is, at what term what development is occurring? That is just an outline, rough outline, that at what points, what months, different development features are there. For no formal staging of the fetal period is there, but it's just the monthly changes that you see and what has regularly been observed, that they have made out this. Beginning of the ninth week or the third month, most striking changes occur is, as I've told you, slow down in the growth of the head compared with the rest of the body. And then the head constitutes half the crown heel length of the fetus. So the head uh, growth is going to slow down, and the rest of the body is going to grow more. In the third month, as you see, the face is becoming, as we've said already, by the third month, the fetus is looking more human like. That is more what is the normal appearance going to be. Eyes, which were initially directed, because when they start to appear, you study the development of the eyes, they are more laterally placed. In this time period, there, because of the growth of the size of the head, they have started to move on the ventral aspect. That is where you have the normal position. The ears, they were initially developed at the level of the neck, but gradually as the growth increases, these ears, they ascend up and they come to their definite position at the side of the head. The limbs reach their relative length. Comparison with this, the lower limb is still shorter, whereas the upper limb, they are more near to the normal levels. The limbs have developed, or there's the upper limb paddle and the lower limb paddles, they start to appear. Then ossification starts in the long bones and the skull, you can see by the 12th week. Genitalia are the same, and they can be estimated the same. The sex, that is, you cannot make out as yet what is the male or the female, but by the 12th week, it is a rough estimation that that is around 4th to 5th month, whether a baby is male or female. At 6th week, the intestinal loops, because the abdomen is small, it cannot contain all the intestines, so that is protruding out from the umbilicus, and this is a physiological phenomena. It's not abnormality. This is called herniation, a physiological herniation. And when the abdomen grows in size 12th week, they're large enough, then these loops are going to come back into the abdomen because they can be accommodated. At the end of the third month, small amount of reflex activity, showing that there is small amount of muscular activity that can also be there. So basically, at the initially, face is more human looking, eyes and ears are at their normal position, limbs have started to appear, Then the nearly the final lens, primary ossification centers start to appear, bone genitalia, their intestines, that is the abdomen, is also developing, and small amount of muscular twitching can be felt. At 9 weeks, the liver, as we said already, the first was by the diffusion nutrition, then the blood formation of the islands were there, then the liver is going to be the major site of erythropoiesis, and then this gradually going over to the spleen, and then the bone marrow takes over. So this at weeks, liver is the major site of erythropoiesis, that is the blood formation. And end of the 12th week, activity decreases in liver and began in spleen, and gradually it is taken over by the bone marrow. Urine formation begins, is discharged through the urethra into the amniotic fluid, and fetus also reabsorbs some amniotic fluid after swallowing it. And if there is some abnormality in the fetus, then there is going to be hydramnios, that is increased amount of amniotic fluid in the amniotic sac. If you see this, this is herniation, as you see. That is this is the chorionic sac. This is the intestines which are protruded out because the size of the abdomen is small. And this is the 11th week, the intestinal abdomen. Then in the 4th and the 5th months, the fetus length gradually increases. Round length is roughly this 15 centimeters. The weight increases little, and by the end is still less than 500 grams. That means 4th to 5th week. And if the baby is born at this age, will not be able to survive. Ossification still goes on. Ovaries can be a differentiated ovaries with primordial ovarian follicles can be seen with the oogonia which are there, and then the baby is also covered with small fine hair which are called the lango hair. Eyebrows and hair head are visible. 5th month, or movements of the fetus can be felt by the mother, which is called the quickening. This small amount, that the movement of the baby, when the mother says, I can feel the baby moving, this is roughly in the 4th and the 5th month, and this phenomena is called the quickening, and that can be seen in the ultrasound. The mobility is there, and this is what we call as quickening. So ossification goes on. Hair, lango hair, small, fine, soft hair, they develop. Weight increases slightly. Ovaries, they are differentiated, and the primordial follicles with the oogonia all can be seen with the ultrasound. If you see this, this is gradually the big size of the head as compared to the rest of the body. Then gradually the size of the head is going slow, as you see, and when you reach the final age, that is the 38th week, the body length is more as compared to the head. So that is gradually at this fetal period, the biggest change is the head size becomes small, and the growth in the head size is less as compared to the rest of the body. And then at the 6th month, the born early in the 6th month, baby has great difficulty in surviving because your central nervous system is not yet differentiated, and the respiratory system. As I told you, the surfactant is not enough to keep the alveoli patent, and so the baby cannot breathe sufficiently, and there is the respiratory distress syndrome results. So at this stage, both these systems, which are the major systems, that is central nervous system and respiratory, they are not differentiated, and there is no coordination between the two. So this is critical if the baby is born at the 6th month. Skin of the fetus is reddish. It is slightly wrinkled. It is covered by the vernix caseosa, which is the sebaceous gland secretions which are there, which covers it as the oily secretion, which it protects the baby from abrasions, chapping, and also from the effects of the amniotic fluid, exposure to the amniotic fluid. So that is basically, it covers the soft skin of the baby. That is called vernix caseosa, which is basically the secretions of the sebaceous gland of the hair follicles, which protects from abrasion, chapping, and from the effects of the amniotic fluid. Fetus has a crown in it has increased to 25 centimeters, and the weight from 500 has increased to 1,100 grams. 6th to 7th month, the infant has a 90% chance of surviving, that is after 6 months. That means CNS and the respiratory system is still progressing more. In this stage, even brown fat, because the baby is not able to control its temperature, body temperature, so brown fat is more. The site of heat production in infants seen at the root of the neck, back of the sternum, and in the perirenal around the kidneys. And there is considerable subcutaneous fat, so more of contouring of the baby is there, and brown fat is more. Uterus is formed. Then there is, in female, the canalization of the vagina can be seen. The testes there, because they have formed in the at the level of the lumbar vertebra, then these have to descend down into the scrotum, so they have begun to descend, located along the posterior abdominal wall. type 2 pneumocytes in the alveoli which produce secretes surfactant. They have also started to. There are two types of pneumocytes, one which are respiratory and the other which produce the surfactant. So type 1 produce the respiration exchange, and the 2 is the pneumocytes which produce the surfactant. So at this stage, the interalveolar walls have begun to secrete surfactant. So the baby, roughly 6th to 7th month, the baby has chances of survival. Still, critical care has to be given. The fingernails are present at the 12th week. So all these features, they are gradually, we saw in the 5th month, we saw the ovary developing, and we could see the primordial follicle, small mode. In this, the uterus is also, canalization is there, testes have developed which start to descend down into the scrotum. Then CNS has matured and given intensive care, and if the respiratory system is still to be supported by the artificial amniotic, this surfactant has to be given, as I told you earlier, or by the steroids to stimulate the production of the respiratory system enough to the level so that the baby can survive. And bone marrow has become the major site. Initially, posteriorly, we said that it was in the 5th month. We said it is the ovary, the spleen, and the liver which were forming the blood cells. Now, but at the 6th to 7th month, we have said that it is about the bone marrow which has become the major site of this process. So nearly reaching, you can see, gradually reaching to all the levels of the normal full-term baby. Then again, gradually white fat is increasing. Survive if born prematurely at this stage, that as we've said at 6 and 7, the weight approximately becomes 3,000 to 400 grams. White fat is approximately 16% of the body weight. Initially it was 8, then it increases to 16%. It's said that fetus adds about 14 grams of fat per day, less, as in the last week it is less. Male fetuses are longer, weigh more at birth than the females. That is just the tries to assess that whether it is a male or a female. Testes are normally at the 7th month in the scrotum. In the full term, male infants, premature male infants commonly have undescended testes. So all these changes have gradually occurred. One of the, again, most striking is growth of head is slow, rest of the body accelerates, and growth of the body accelerates, but that of the head slows down, as I've shown you in that previous picture. Then during the last 2 months, the fetus obtains well-rounded contours, that is full or full appearance of the baby. By the end of the intrauterine life scale, whitish fatty material, that is, I told you, the vernix caseosa, that is still covered. And the end of the 9th month, skull has the largest circumference of all parts of the body, an important fact with regard to its passage to the birth canal. So that again is reaching the normal size, and because it has to pass through the birth canal to start the delivery process. At the time of birth, the weight of a normal fetus has to be 3,000 to 3,400 grams. The crown ramp length is about 36 centimeters, and crown heel length is about 50 centimeters. So the birth weight has to be 3,000 to 3,400 grams. Sexual characteristics are well developed, and testes should be in the scrotum. So all these features have to be there at their respective positions so that only we can call it a full-term baby. You see this, the size gradual changes at the 3rd month, what you saw, and the 5th month. You can see the head size is slow, the rest of the body is developing. The limbs, they are reaching you can see in the lower limb, they are more adducted. Now they have reached rotation is there. There is lateral rotation of the upper limb and medial rotation of the lower limb is there. And then you can see on the that is why the extensor surface of the upper limb is on the posterior aspect, and the extensor surface of the lower limb is on the front. So all that is there so that you can see gradual changes, and at birth the appearance of the baby. These are the healthy newborn babies with all the features on their position. Ears, as you can see, on the sides, the eyes are placed front, and the limbs are in their well developed position. Then what is the expected date of delivery? The expected date of delivery of fetus is that, as we said, 266 days or 38 weeks, or what we said, 28 days, 280 days or 40 days, again from LMB or from the date of the fertilization. Approximately 12% babies are said to be born 1 or 2 weeks before the time of expected birth. So born much earlier, they are called premature, and if they are born still later, they are called post-mature. There is this Negley's rule for estimating the expected date of delivery. We have to complete the 9 months. From the date, if you go 3 months backwards, 9 months plus 3 months would be 9 months full year. And if you go them from add a year and 7 days, that is if you go 1 year ahead, that is going to be again that. So it's you have to complete 1 year. That is the negligee rule for estimating the expected date of delivery. Count back 3 months. That is from the expected date of delivery. That is going to be there. That means you start from that. It basically it is going to go forwards. The growth of the baby is going to grow forward, but it is going to reach that level, that date, which is about roughly from the LMP, it is going to be 3 months before that. So that is the a rough way of estimation of the delivery. You have to complete the 9 months, whether you start counting them from in front or you start counting them from behind, but you have to complete, because the year is 12 months and you minus 3 or you add of the year 3 months from the first day of the LMP and add a year, you go ahead. That's if you can remember it. A valuable tool for assisting in this determination is ultrasound. Provides accurate 1 to 2 days measurement of crown rump length. Measurement commonly used in the 16 to 30 weeks are, again, as I told you, the biparietal diameter, head and abdominal circumference, and the femoral length. These are basically to assess the normal growth of the baby. The accurate determination of the fetal size and age is important for managing pregnancy. If the mother has small pelvis and the baby size is greater as compared to the pelvis, then the surgery has to be planned. And or if the baby has a birth defect, then again whether to allow the baby to grow normally or to make the baby go through C-section. So the determination of the fetal size and age is very important. Whether if it is a premature baby, whether a normal birth through passage can be survived by that baby or not, or whether there is an abnormality the baby would not be able to pass, or all those factors. So you have to consider whether to allow a normal delivery or whether to go in for a C-section. What is post-maturity syndrome? Post-maturity syndrome, prolongation of the pregnancy for 3 or more weeks, is called post-maturity syndrome. Beyond the expected date of delivery occurs that is for 3 weeks or more. That is called a post-maturity syndrome. Develop the post-maturity syndrome have increased risk of mortality, because the growth of the survival kit for the baby, that is all the placenta, etc., that cannot be compensated after about 3 weeks. So there are chances that the baby may be in distress because of the labor. The baby, if normal labor has not started by injections or by drips of syntocinon, the labor is started to prevent the baby from going into any problem. A baby that is born after 3 weeks roughly, which is considered to be a post-mature, is going to show you all these features. It has a dry, parchment-like skin, and it is often overweight because of the growth to continuing. There are no languor, they are finished. The next case yours finishes off their long nails and the alertness increases. So all these features, they are considered that the baby was a post-mature baby. Factors influencing the fetal growth. Poverty linked to poor prenatal care has been an influence on the prenatal development. Children at a younger age results in women in poverty more likely to have children at a younger age, because the fertility age is very long and they have a low birth weight. Expecting mothers have little education, therefore less awareness of what is the hazards of alcohol, drugs, smoking, etc. So this can affect the growth of the baby. Poverty, mother's age, we've said 16 to 35 is a good environment. 35 onwards, chances of more abnormalities are there, and if it is 16, again the chances of abnormalities are there. Fewer complications, have high risk of under 16 and over 35 have a preterm labor, premature babies. Risk increases in poverty people. Okay, so young teenage mother under 16 and mothers over are exposed to risks of miscarriage, premature births, and birth defects. Malnutrition, mothers who gain less than 20 pounds during pregnancy are at an increased risk for having a preterm or a low weight baby. So the iron and iodine is very important for because iodine gives a normal CNS development and iron for the blood formation. So iron deficiency increases the risk of miscarriage, stillbirths. Also, adequate prenatal care improved results of newborn, normal newborn. Drug use, heroin, cannabis, all these also result in abnormalities. Then there's the alcohol used to disruption of fetus brain development, affects heart problems can be there. Tobacco, smoking, nicotine, carbon monoxide, all this nicotine constricts the blood vessels, blood flow to the fetus is less from the placenta. Carbon monoxide reduces the oxygen flow to the fetus. So all this leads to poor development of the baby. Infections, all sorts of infections, viral infections can be there, HIV is there, bacterial infections. So risk of fetal infections during pregnancy is the highest in the third trimester. However, early outcome, it can be worse and fatal because when the differentiation is going on, more chances of fetal abnormalities. Stress, development, mother experiences affects the mother, baby. Environmental toxins in pregnancy, air pollution, smog, etc., mercury, lead, ethanol, all these can affect the growth of the baby. Then genetic factors and growth retardation. Genetic factors also cause intrauterine growth retardation. That is, repeated cases of this condition in one family indicate that recessive genes be the cause of the abnormality. That is, all the genetic factors. Structural and numerical chromosomal aberrations we'll study next have also been shown to be associated with cases of fetal retardation of growth. That is, all these factors, they can affect the growth of the baby. Multiple pregnancies. If repeated pregnancies are there, mother has poor health, that is, the weight of the baby is going to be considerably less. So then these were all the factors which affect the growth of the baby. Then that was the procedures for assessing the fetal status. Or tests, all that you can do is to assess that whether the baby is progressing normally. Perinatology is the branch which is concerned with the well-being of the fetus and the newborn infants from, that means, 24th week, 6th week after fertilization to 4th week after birth. So that is before perinatology. So that is before birth, that is peri, and natology is after birth, at birth as well, up till the 4th week. So both these, the is concerned which is with the well-being of the fetus, that is the fetal period, and newborn infants roughly for 1 month. So combined aspects of obstetrics and pediatrics. That means before birth, that is the obstetrician, that is the gynecology people, they are going to take care of the baby, and pediatrics is 1 week, 1 month after the birth of the baby. So that is what is done for perinatology people. They are going to assess it. How is the perinatal diagnosis being done? Assessing the growth and development of the fetus in utero is by ultrasound, maternal serum screening, amniocentesis, and chorionic villus sampling. These are the tests which are commonly done to see the normal development of the baby. Combined, these techniques are designed to detect malformations, genetic abnormalities, overall fetal growth, and complications. So all this tells you whether the baby is growing normally or not, or if there is any malformation, whether it is structural or it is genetic, or and the complication is there. Ultrasonography, wide availability, low cost, lack of known adverse effects. So this can be seen for all sorts of abnormalities, normal growth, age, length, all this can be done starting from very early age. The fetal age and growth are assessed by this crown rump length, as we've already said. After that, the combination of measurements, including biparietal femoral length, and all that is done by ultrasonography to see the age. So determination of the fetal age and growth is crucial in planning the pregnancy management, especially for the low birth weight, because it may be critical whether a normal birth has to be allowed or it is for the, because baby, if the baby is low birth weight, chances that the baby may not survive during the normal birth canal. So that has all to be seen by all this ultrasonography. Studies show that ultrasound screened and managed pregnancies with low birth weight will reduce the mortality rate by 60% compared with the unscreened baby. So by repeated ultrasonography, you can see all the effects that are there, and you can manage by the size of the baby, and you can have all features that give you what sort of delivery has to be planned and whether to prevent the baby from dying out. So ultrasound screened and managed pregnancies with low birth weight, that is, which are there reduce the mortality, that is the chances of death of the baby are reduced by 60%, which unscreened, that is you do not follow the stepwise development, then you do not know whether the baby is in the critical stage or whether the normal development is there. Diagnostic amniocentesis, this is done if you detect some genetic abnormalities, and if there is a family history of genetic abnormalities, you do this amniocentesis, whether through the transabdominal you take out the amniotic fluid and then you test it, because it contains certain chemicals, it contains certain cells of the baby from the skin of the baby, and you can do certain testing whether the baby is genetically normal or not, or whether there are other problems. So indication by when we do amniocentesis is when the mother is more than 35 years of age, there is a history of Down syndrome, that is genetic abnormality, chromosomal abnormality in either of the patient, or the baby, first baby was abnormal. Women who are carriers of X-linked disorders, certain genetic diseases are there. There is a history, it's a history of neural tube defects. All that there's a previous history of any sort of abnormality which is there, or genetic problem, or in born errors. In that, amniocentesis is done, fluid is taken, it is tested whether the baby would be affected, the oncoming baby would be affected or not, and if there are more chances that the baby is affected, then whether the pregnancy has to continue or not. So that is what we call as diagnostic amniocentesis. We diagnose whether the baby is going through any sort of problems. Then these are all the indications when you recommend that amniocentesis has to be done, because we've said by above 35, because we say more chances of abnormalities. And then why are more chances of abnormality? Because your cells, they are exposed only, well, the second meiotic division does not start complete until and unless there it is fertilized. So the cells, the oocytes, they are in the stage before that. So that is more chances of abnormality because they're exposed for a longer period. Then is alpha fetoprotein. This is maternal serum screening. This is a very important substance which is produced by the fetal liver, and this has in certain disease conditions it is going to be high, and in certain conditions it is going to be low, and that is also reflects what are the problems. So 14 weeks after the last normal menstrual period, there it is in a high condition. Small amounts normally enter the amniotic fluid and the placenta, and it is decreased at 30 weeks. Alpha fetoproteins and fetal anomalies, very important in the central nervous system. The neural tube defects show you a very high range of alpha fetoprotein. So therefore that this screening is done, and if it is high level, then you should suspect that there is a neural tube defect. Amniotic fluid concentration is measured. Approximately 99% of fetuses with severe defects can be diagnosed prenatally if there is high levels of alpha fetoproteins. In the open neural tube defects and the alpha low chromosomal are low in chromosomal abnormality. So both levels, both extremes tell you that what the baby is suffering from. Spectrometric patterns. Estimation of amniotic fluid by this method may be used for assessing the degree of erythroblastis fetalis. In this, you have the hemolytic disease of the newborn, that is certain factors, that is the coagulation factors, they are missing the factor 8, and that by this pattern of the blood, you can assess whether the baby is having hemolytic disease of newborn or not. Then sex chromosome studies can be done by the presence of the sex chromatin, that is the nuclei around the nucleus, that is the unactive X cell that was related. It's going to be condensed and it acts as a sex chromatin in the nucleus. The cells recovered from the amniotic fluid, useful diagnostic in sex-linked hereditary diseases. You can see that. Then chronic villus sampling, CVS. This is made weeks earlier when the CVS is performed compared with the amniocentesis. Diagnostic value of chronic villus samplings is biopsies of the chorionic villi are used for detecting the chromosomal abnormalities, inborn errors of metabolism, and X-linked disorders. So before even amniocentesis is done, this is in very early, and whether you can 10 to 12 weeks of gestation, and you again see the same things, that is chromosomal abnormalities, inborn errors, and X-linked diseases, and whether you want to allow the baby to grow on, whether before allowing the baby to grow later, then doing the amniocentesis and then detecting whether the baby is normal or abnormal. And when the mother has carried the baby for so long and she is so attached to the baby, so it would be difficult to finish off the pregnancy. But in this very early stage, you can make a diagnostic or a medical abortion can be done, because doctors induced it because the baby is abnormal. Chances are more because there is a history of abnormality, genetic abnormality. So this chorionic villus sampling is done in a very early stage, in those mothers who have a previous history of an abnormal baby and those who have a family history of such abnormalities. Risk of fetal loss for chorionic villus sampling is approximately twofold greater than with the amniocentesis. So you are going to, so chances of risk of fetal loss with this test is more critical. So you have to do only with specific people who have a history. Indications for using the test include advanced maternal age, again, same 35 years and older, previous history of genetic problem, presence of maternal disease, abnormal ultrasound or serum screening tests. All these they give you. If there is a history of all these, then you can do a test, a CVS. Cell cultures and chromosomal anomalies analysis. This is fetal sex and chromosomal aberrations can be done. Cultures are taken from the cells, and autosomal abnormalities can be done, or these can be checked by the cells in the amniocentesis. Fetal transfusion, fetus with hemolytic disease, if there is a problem in the coagulation factors, they can be treated by intrauterine blood transfusions. That is before the baby is born. That is done when there is anti-RH immunoglobulin, because when the mother is negative and the baby is positive, there is chances of fetal breakdown. Need of fetal blood transfusion is reduced nowadays owing to the treatment of this, because this was done initially previously, but now they give you immunoglobulins which prevent from the exchange of the positive cells going into the mother and then producing antibodies, and those antibodies coming back to the baby and destroying the baby cells. So that is feature is prevented, and it is by this anti-RH immunoglobulins, and the transfusion is prevented. The breakdown of the blood cells is prevented. Fetoscopy, to see by the fiber optic lighting instruments to see whether any congenital anomalies are there on the body. Percutaneous umbilical cord blood sampling can be done by the umbilical vein for certain diagnosis. Fetal monitoring, continuous fetal heart by the oxygenation can be done. So all these are continuous monitoring of the baby. Computerized tomography and MRI, all these can be done, seeing the whether the baby is going producing normal uh, development or there is some abnormality and you need some intervention. All these tests are done for community CT scan and MRI to plan the pregnancy and the treatment. Fetal medical treatment for infections and other problems that can be done. Cells are tested via the umbilical vein. Fetal surgery in very advanced cases, where there is high recommendation that the cause of risk to the mother infant procedures are only performed in centers with well-trained teams. Certain before birth surgeries are also done. Stem cell transplantation and gene therapy is done. Hematopoietic stem cells for treatment of immunodeficiency and hematological disorders is concentration upon disorders. So, because the fetus does not develop any immunocompetence before 18 weeks gestation, it may be possible to transplant. So, that is stem cell is because immunity is not developed before 18 weeks. So, the transplant the cells before this time is without rejection, so that there is some abnormality and some disease is highly suspected. So the stem cells, to prevent that problem, stem cells have to be transplanted to change in the genes. That is done very early, before 18 weeks, because the immunity system of the baby is not developed as yet, so it will not reject what all cell is implanted. That is all about the fetal period. That is the stem cell transplantation. All these tests, investigations are done. That can be done. Then you can have a fetal medical treatment for infections. Fetal surgery can be done. That is in very high, uh, performed with only well-trained teams. Then you can have CTI. You can do computer CT scan and MRI, where you can plan fetal treatment. If you are suspecting something, then you have percutaneous umbilical cord blood sampling, fetal monitoring. All this is for the progress. If you're suspecting that less of oxygen is there, there are some abnormalities, there are genetic disorders, there are certain infections. All these tests are done so that you can assess the normal or the abnormality of the baby. Fiber optic direct invasion of by this lighting instrument that can see the parts as such, that whether they are developing normally or they are not. Fetal transfusion were given, but now they, to prevent all this blood. So the fetal transfusion was given when there was RH incompatibility, that is, the breakdown of the cells was to be replaced. But now it is more developed system is there, in which the anti-immunoglobulins are given, which prevent this breakdown, and they are going to prevent this process. That is, when there is negative mother, positive baby, and the positive cells of the baby, they go into the mother, produce antibodies which were not already there, and these antibodies come back against the baby cells, and these are then going to destroy the baby cells, which is going to result in hemolysis or the breakdown. To prevent that, anti-RH immunoglobulins are given so that no antibodies are produced and the baby does not become jaundiced. So all this cells, cultures, chromosomal analysis, chorionic venous sampling is there, again to detect whether the baby is normal or the baby is not normal, and whether you would like to let the pregnancy continue or not, to save the mother from the afterbirth distress. Alpha protein diagnostic amniocentesis is important, ultrasonography, all this prenatal diagnosis. So basically, it is ultrasound, maternal serum scanning, amniocentesis, and CVS. These are the four tests which are done, and in under these different ultrasound as MRI and CT scan as more sophisticated one. In amniocentesis again and chorionic assembling, you just to see whether there is some genetic problem or some other abnormalities are there. So that was about the fetal period. Okay. These were the tests which can be done for the assessment. Then what can be the factors which can affect the growth of the, influencing the growth of the baby. In that we've said it is poverty, mother's age more than 35, less than 16, maternal nutrition, drugs use, alcohol, tobacco, nicotine, all these infections, all these are stress, environmental toxins, all these, they are going to affect the growth of the baby. And what was post-maturity syndrome? That is 3 weeks or more after the baby is born. And what are the factors which the baby shows? That is dry skin, or it is overweight, and alert baby, and decreased because the growth has been more, less of onyx-caseosa, no lango hair, and long nails. All this shows you it is, these are signs of post-maturity. So that was about the fetal period. Next time, that finishes with the general embryology. We are going to do with the fetal period. That is, after fetal period, we have discussed the some all the normal factors which are going to be there. What all tests have to be done, birth defects, what things lead to what sort of birth defects. They can be structural, they can be genetic, they can be morphological, all factors which can lead to the abnormalities. That we will do inshallah in the next lecture. And a few words about the amniotic fluid, which is very important for concerned with the amniocentesis. So where it is produced, what is its circulation, what is its function, all that we will do inshallah in another lecture.